Hey y'all, my name is Madi Cheever. I'm a registered dietitian nutritionist, certified health education specialist, type 1 diabetes specialized coach, and the face and founder of Type 1 Type Fun. And I also live with type 1 diabetes. I share stories, resources, and tips to make diabetes management easier and a lot more relatable and fun. Today, we're joined by Dr. Amir Harari, an endocrinologist with a truly unique background. He spent 2 decades serving in the U.S. Navy, traveling on missions to remote islands to bring medical care to people in need. Now, he's dedicated to helping patients here at home manage diabetes. Dr. Harari's located at Endocrinology Associates in Scottsdale and Chandler, Arizona. Thanks for joining us today. Dr. Harari, thank you so much for being here today. I'm so excited to chat through so many amazing things. And obviously, I know I mentioned this to you already, but I grew up Navy, so getting to film this with you is such a privilege and so near and dear to my heart. So thank you for being here. And I would love if you'd be willing to tell us how you wound up joining the Navy and then how it did evolve into endocrinology.
Sure. So thank you for having me. I really appreciate it. Um, so I grew up in Northern California, in Berkeley, California, and I really had no military background in in my growing up or with my family. I went to my undergraduate at UC Berkeley, and back then in 1985, when I was applying to medical school, there was a centralized application process. And basically, you could check off all the schools that you wanted to send your initial application to, and it cost $10 per school, which was a lot for a junior in college.
Yeah.
Um, so one of the schools had no application fee. It was called Uniformed Services University of the Health Sciences. I had never heard of it, and I said, "Well, that one doesn't cost anything. I'll send my package there also." And they were the first to accept me. And it's a military medical school. It's funded by the services, it's Army, Navy, Air Force, and Public Health. And I got accepted and I said, okay, they are going to pay me to be an ensign for 4 years and go to medical school and get an education and serve my country at the same time. And so that's kind of how it happened. It was sort of, I didn't know any better, and I got a good offer. Uh,
Hey, sometimes that's how it works, huh?
yeah. And the way the school worked at the time is for the 4 years of medical school, you owed back 7 years on active duty, not including any of my training. And I did 5 years of training. So I was committed to 12 years on active duty. And then once I reached my 12-year mark, I was already an endocrinologist. I was just got stationed in San Diego. Life was pretty good. And so I stayed and I spent a total of a little over 21 years on active duty.
Wow, that is so phenomenal. And thank you for all that you have done. I sure know how lovely San Diego is. We were also stationed there when I grew up. I actually graduated high school in San Diego and frequent there visiting. So it is lovely. We love the vibes there. And I'm glad that that was a part of your experience too. I feel like it's such a good spot to be in, especially for the Navy. I know that all the branches go different places, but I think it's a pretty good spot. Maybe I'm biased. I don't know.
Yeah, that's great. It was great.
It is, yeah, and I think that there's so many things that come into our story and our journey, and so, I know that some of us are listening because it's a podcast, but for those who actually get to see this podcast on some platforms, we're able to see things. We have some photos, from a humanitarian mission that you worked on in the Navy. Could you tell me a little bit more about what this was and what you were doing?
Sure. So, throughout my career, I had the privilege of serving on two different ships. The first ship was between 1991 and 93. It was called the USS Arkansas. It was a guided missile cruiser. My second ship was the USS Peleliu, which I was on from 2005 to 2007. And that's a type of ship called an amphibious assault ship. It kind of looks like a small aircraft carrier. And the mission of the ship is to take Marines out to where Marines need to go. So we had Marines on board, we had helicopters, we had Harrier jets and other kind of landing craft. But it was a very capable ship because it takes Marines to places where they may be in harm's way. We had a pretty robust medical department. We had 4 operating rooms. We had about an 8-bed intensive care unit. We had ventilators. When we deployed, we had a general surgeon, a nurse anesthetist. So we had a lot of medical capabilities. And the Navy recognized that, and they wanted to use some of those medical capabilities to do humanitarian missions also. There are 2 large Navy medical ships, the Comfort and the Mercy, which just do medical missions. But the Navy was expanding and starting to use some of these warships to do this. So we had a mission where it was not only our crew, but we had Army, Navy, and Air Force from the United States medical personnel. We had medical personnel from foreign militaries. We had people from England. We had people from India. We had people from Japan. So it was a multinational medical mission. And then we also had humanitarian organizations come on board. So we all got on our ship and left San Diego. And the first place we went was the Philippines. Actually, first place we went was Hawaii. We didn't do a medical mission there, but we picked up a surgeon, a civilian surgeon, who would go to the Philippines and do thyroid surgery for people who had large goiters. So the first place we went to was the Philippines. It was called the Bicol region. And we had surgeons doing thyroidectomies. We had ophthalmologists doing cataract surgeries. We had the CBs on board, and they took their heavy equipment and went ashore and built buildings. There was a river there that was clogged with ash from a volcano. And so the CBs cleared out miles and miles of ash and restored water supply to some of the local villages.
Wow.
Um, so it was a pretty amazing mission. My role as an internal medicine doctor, we would go ashore and do medical clinics. Um, Honestly, treating chronic conditions is not something you can do by going ashore one day at a time and never seeing these people again. So as far as those kind of things, helping people with diabetes and blood pressure, things that I would do in a hospital, I really wasn't able to do much for them. That particular picture that you found on the internet that's still circulating out there, 20 years later, um, I remember that gentleman. I remember he was an older, kind of emaciated looking man. And he came in and he just said he wasn't feeling well and his belly was really big and his arms and legs were very skinny. Um, and I remember looking at him and thinking there was something very bad going on here. Um, but unfortunately, I had no ways to make the diagnosis. I couldn't do lab work. I couldn't do imaging. And he obviously needed to be in a hospital and get a full evaluation. And so one of the things this medical mission showed me was how privileged we are in America with all the faults of our medical system. For the most part, we can attain the care that we need, and we're not going to let these conditions develop and fester. So that was a very humbling and eye-opening experience for me. I saw this man for about 15, 20 minutes, and I listened to his heart and his lungs, and he wasn't in any imminent danger, but something wasn't right. And unfortunately, I really couldn't do much to help him. The people who could, the ophthalmologists who could do cataract surgeries, the CBs, the orthopedic doctors, they could actually do some pretty life-changing interventions during this mission. But it was pretty remarkable. I mean, we went to the Philippines, we went to Vietnam. So we were actually the first Navy warship to go into Vietnam since the Vietnam War. That was very interesting. We went to the Papua New Guinea, went to the Solomon Islands, which is where John F. Kennedy's boat, PT-109, was crashed. That was pretty historical. And then we lastly went to the Marshall Islands. And actually in the Marshall Islands, I did get to go to a hospital and work with one of the clinicians there treating people with diabetes, because in the Marshall Islands, a lot of people of Polynesian descent, a lot of diabetes there. So it was about a 4 or 5 month mission that we were out and went to about 5 or 6 different places. So it was eye-opening. It was very gratifying. It was very nice to work with multiple different people from different backgrounds to bring them all together for one mission. And that's one thing that being in the Navy was really for me all about is multiple people coming together, working for something bigger than themselves. And in the civilian world, I mean, I can still practice good medicine and do a lot of things, but I don't feel like I'm part of that kind of one bigger mission. And that was something that was pretty special about being in the military.
Yeah. Yeah, I couldn't agree more. I know I wasn't active duty myself. They didn't want me to have type 1, but, even seeing that throughout my childhood, it's so true, and it's so special, and you're right, it is something bigger than ourselves, which is, um, really cool and important, and there's so many amazing details to your story, especially too in healthcare. Oftentimes, we have a lot of heart, right? But we don't always have the ability to do everything we wish we could, right? And sometimes that it just is what it is. I really am hopeful that that individual was okay. And yeah, if you have the option to take a look at that photo, if you're not already seeing it, then it's a pretty powerful one, I think. And we also made sure to include a photo from what I believe is your retirement. So looking sharp there as well. And so with that being said too, especially with this idea of diabetes coming up now, um, have you seen any changes in maybe quantities of people being diagnosed or proportions of type 1 versus type 2? And if you have seen those changes, maybe why do you think that is?
Um, there's definitely an epidemic of type 2 diabetes. We are seeing many more patients. If you looked at the statistics, the curves show more and more people are being diagnosed with type 2 diabetes. And interestingly, after COVID, there are statistics showing that more and more patients have been treated with type 1 diabetes. And I certainly have seen autoimmune conditions develop after people have had an infection with COVID. So I think there has been an increase of both type 1s and type 2s. As you know, epidemiologic data is certainly not my strong suit, and I'm not going to be able to tell you why this is. Obviously, with type 2 diabetes, it has to do uh, with obesity epidemics. It has to do with food quality. It has to do with personal responsibility. It has to do with better access to medical care, and people are actually going and being seen and getting diagnosed. And whenever you see an uptick in a disease process, you always have to wonder, is it because we're looking for it more, or is it really more common?
Yeah,
Yeah.
it's a wonderful point to make.
Yeah. I will say I'm not the doctor making the diagnosis of diabetes in most cases. That really falls to the primary care doctors. That's where
Yeah.
people need to go and have their regular checkups, get their regular evaluations, and make sure these other conditions aren't developing. But there's certainly been no shortage of patients who develop diabetes.
Yeah, absolutely. And that's actually I feel like I'm pretty aligned with what it is that you've found as well, because I tend to focus on the adult type 1 population, and more recently I've gotten anywhere between 25 to 60 plus year olds who have been diagnosed with type 1, and their whole world is rocked, and that's where I come in and say, "Hey, let's make it make sense." But it definitely, yeah, if anyone's not familiar, type 1 diabetes is autoimmune, right? So, theoretically speaking, it's not because of lifestyle, it's not because of something someone did wrong, it simply is. And what we do from there is treat it and learn to live with it. And it can make a big difference to feel supported. And so I'm kind of curious, what would you say is the number one issue that you see in people with diabetes, or maybe the biggest challenges that they're dealing? What are the issues they have, the challenges they experience?
Um, I always tell patients, I mean, I don't have diabetes, so I don't know what it's like to live with diabetes. But I certainly see a lot of people who deal with it day in, day out. And the thing about diabetes is it impacts every single aspect of a person's life, from how they eat, how they sleep, how they stress. You know, every single thing that they do in their life has an impact on their blood sugars, and vice versa. And they can be exhausting. I say, even people who have cancer, they can have times in their day or times in their life where cancer doesn't have an impact on them. But diabetes is just always there. Sometimes it's here, sometimes it's here, but it's always there. And that can be a burden. That can be a very large burden. And um, diabetes burnout is real. People will say, you know what? I'm just tired of this. I've just had my third eye injection for my retinopathy. I'm having problems with my feet. Maybe they just had a cardiac event, and it all ties back to their diabetes, and they may be doing everything they can, and these things sometimes still can happen. And it can be just very daunting. It can be very overwhelming. And like you said, for a new diagnosis, especially if this is someone in their 50s or 60s, which we see not uncommonly, um, it's life altering. It's life affecting.
Yeah. It is, it is, and I think maybe I'll say it's not to scare anyone, but, there is ways to test for the markers for type 1. We'll make sure to have some info about that in the show notes. I don't wanna take away from our conversation today, but if your loved one, your direct loved one has type 1, you can get tested for these markers and potentially be proactive about solution there. So just wanna say that too, especially with all the potential adult diagnoses that are happening lately. And I'm kind of curious too. Do you have any thoughts on what is happening in the stem cell research slash transplants? Anything you want to add to that conversation?
Sure. Um, it's a fascinating field. You know, the organization that used to be called JDRF has put a lot of emphasis or a lot of funding into research. Lots of private groups are doing research and looking for ways to harness the islet cells and protect them from the autoimmune injury that a person with type 1 diabetes will develop. And there's exciting research going on with that. I will be honest, it's not something I've been following real closely because I still see that as probably 5 to 10 years down the line as something that would be in my clinical practice. In my day-to-day practice, when I'm seeing patients every day in my office, I'm trying to focus on medications, pharmacology, technology that I can offer them right now. And I kind of feel that's my responsibility to have an understanding of that. So the islet cell transplants down the line, I think potentially could make type 1 diabetes a thing of the past. Um, you wonder about costs. You wonder about scalability. I mean, we've heard about pancreas transplants for a long time. We've heard about islet cell transplants for a long time, but none of those have really scaled up to a place where it's had a huge impact on my practice. So I'm optimistic, but I'm skeptical. I've been doing this a long time, and I've seen a lot of things come and go. Um, but if they can truly harness an islet cell, have it produce insulin appropriately, and protect it from the body's immune system, yes, I think that's something that will revolutionize type 1 diabetes care.
Yeah, absolutely. And I think ideally we will get to a place of prevention, cure, if I could be so bold. But for now, you're right. Right now, what we have to do is management, strategy, technology, all of those things that we have in place. We learn how to optimize those. And so that the technology side of things, something that changed my life personally was getting on a CGM because I could finally see the data. I could finally start to understand it. And I'm a numbers girly. So when I saw it, I was like, "Oh my gosh, this makes so much sense." Everything clicked, and it literally changed my life. I know that technology isn't always perfect or accurate. Sometimes things stop working. What are your thoughts when it comes to CGM, the tech in general, or the potential errors that can happen?
Oh, I mean, I remember the very first CGM I had access to in my clinic. It was by Medtronic, and it was a box about this big, and it had a real thick wire and something that looked like a toothpick on the end of it. And the toothpick had to be inserted under the patient's skin, and they could wear it for up to 72 hours. And when we did it, no 2 days looked the same. So that was the first generation. Didn't really work too well. CGM technology obviously has come a long way, and if you look at the data for Dexcom, Libre, the new Guardian 4, Eversense, these are very good tools, but they're mechanical devices. They're electronic devices, and electronic devices fail. Uh, they're tested in many different people, but not every person is the same, and it makes you wonder if someone has some sort of unique physiology about them that makes a CGM less reliable. Maybe someone is just clumsy. and they knock it off all the time. So yeah, there are lots of areas where CGMs may not perform as well as we would like. We also have to have realistic expectations, and it's not going to be perfect. How does a person determine if their CGM is accurate? They do a finger stick, right? Well, is a finger stick accurate? Who do you believe more, finger stick or CGM? Most people with diabetes have grown up with finger sticks, so that's what they rely on. But the finger sticks aren't always that accurate. So who's telling the truth? Sometimes that could be a little tricky.
Oh, yeah. And if you have any level of anxiety about that, I will just say, do the best with what you can. It's not always gonna be perfect, but you're gonna make progress, and if you're really unsure, have a good social support network that can help you troubleshoot through those things. Find people, find community, find your T1, your dia buddy, your dia bestie who can help in those moments.
Good advice.
Yeah. Yeah, absolutely. And I think I'm curious. So we've talked a little bit about the stem cells. Is there anything that you anticipate coming up in, let's say, the next 5 years or the next 10 decade, that you think might have a big impact on, let's say, day to day with diabetes?
Um, I'm just not sure if the stem cell is going to be there in the next 5 years. At least not on a scalable level. I think insulin pump technology is kind of the next big wave. I mean, from when the first closed loop system came out, what, maybe 7, 8 years ago with the Medtronic, even from going from one system to now we have, I think, five. Uh, that technology has really improved. The CGM technology has really improved. And combining those together with better algorithms, everyone talks about using AI to make the algorithms better. I don't know what that means. Uh, but those algorithms are going to continue to improve. You're going to have extended wear on the pumps. You're going to have more options for how to wear a pump. Um, Other delivery systems will be coming out. So I think the for the type 1 population, it's going to be better pumps, better CGMs. I think that's going to happen definitely in the next 5 years. In the type 2 population, hopefully getting CGM access more readily available, because it is still a little restrictive, at least for the Medicare patients with type 2. They need to be on insulin for Medicare to pay for it. So as costs come down on CGMs, more people will have access to them. And like you said, wearing a CGM tells you what's going on. Now, studies will show if you put a CGM on a person within the first 48 hours, their blood sugars improve with nothing else changed because they understand what's happening. So I think more CGM availability in the type 2 population, better CGM, better pump algorithms in type 1. I think in the next 5 years, that's what's going to be kind of the main thing I'll see develop.
Oh my gosh, I couldn't agree with you more. When you were saying that, I was like, "Oh my gosh, yeah, the Dexcom potentially extending to a 15-day wear, the Dexcom CGM, or the Eversense CGM being inserted so you might have a less invasive or less visually present option. I don't know, my words are failing me, but I think about the Mobi, this cute little insulin pump that looks like it's designed for an American Girl doll. Now is does the same thing as the T Slim, but just so much smaller. And I think of the Beta Bionics iLet, where there's no more carb counting. All of these systems have their pros and cons for sure, but finding that system, something you said earlier is not everyone is the same. So finding the systems that work for us. That's why I love that there's so many options out there. Sometimes it can be overwhelming, but you have the opportunity to find what works for you. And I think that that is one of those coolest things.
Yes, I agree. Choices. It's great to have choices because it's not one size fits all. And usually I think people can find a system that works well for them.
Yeah. Yeah. And if you can't, again, that's where you communicate, you connect. Maybe it's with your provider, maybe it's with a friend who happens to know more about their personal life. And, oh, okay, well, here's my experience here and there. Not to say that that is perfectly aligned with the evidence or science, but then just knowing a friend, right, makes a difference. And you can learn things and then bring those back to your provider and say, hey, I've thought about this and this and this. Do your research. Say, I heard this and this, right? Don't trust everything, especially with the world of AI. Who knows what's going to happen? But we have to make sure that we are just continuing to communicate and advocate for ourselves. And if you can, then do that. And if not, I don't know, then maybe learn slow and steady, build your way up to whatever feels confident. So this has been so awesome today, Dr. Harari. Thank you so much. And how can people connect with you or your office if you want to? We'll make sure we have any info in the show notes as well.
Sure. So my office, my practice is called Endocrinology Associates. We have 5 physicians, and we also have quite a few nurse practitioners and physician's assistants. We have 2 offices. One's in Scottsdale on Raintree in the 101, and the other's in Chandler on Chandler Boulevard. Um, we see new patients every day, lots of availability. We see obviously a lot of diabetes, but we do all general endocrinology. And if a person is interested in scheduling an appointment, they just have to call and go to our, unfortunately, there's a phone tree, as there is with any office. Uh, but be patient, navigate through the phone tree, and go to scheduling and just say you would like to schedule a new patient appointment. We have a
Okay.
website, paperwork is available and all kinds of things. Information is available on our website also.
Wonderful. And we'll make sure we have that number and that website link down below. And just to make sure for anyone who's not local, we're talking about the Phoenix, Arizona area. So if you are local to that area, then that could be a really fantastic resource for you. So again, thank you so much for your time today, Dr. Harari. It's meant a lot. And I know that you're going to continue to benefit so many people. So thank you for what you've done and thank you for what you will continue to do.
Thank you, Maddie. I appreciate you having me on.
Absolutely. That's it for today, my friends, but the fun doesn't stop here. If you liked this episode and want more real talk diabetes support, come hang out with me on social. Just search Type 1 Type Fun, all words, or head to type1typefun.com for tools, tips, freebies, and real life resources you can actually use. And if this episode made you laugh, learn, or feel a little more seen, feel free to leave a comment, give it a like, share it with someone you love. But until next time, live empowered, be silly, have fun, and eat some carbs.